So thank you for joining me. My name is Kathy, and I'm the practice facilitator for OU Family Medicine for this Rise OK project. And then also we're reducing opioids in seniors in Oklahoma. What we're doing is combining this meeting for enrollment and academic detail kickoff visit. So the meeting for the practice enrollment, I'll be going over the steps on consenting and the practice member survey. And then Dr. Trong, he's going to go over the academic detail kickoff visit. It's a peer-to-peer meeting, and then he will go over the detail aids, and then you can ask questions, and then he'll go over the materials with you. So for the review, you'll receive an email, then it'll come from Stephen Crawford or Carol Kalupi. And then in the body of the email, it has a link for the consent form. Once you click on that link, this is what the form looks like when it loads up on your computer screen. Consent form to participate in a research study, University of Oklahoma Health and Science Center. So you're being asked to participate in the research study. It's voluntary, and you're being asked to participate in the study because you're employed by this practice as a clinician or staff member. If you're a member of the practice, you're being asked to provide consent to participate in the study activities and surveys. The purpose of this study is to provide implementation support to primary care practices in Oklahoma. I want to go give you a brief overview on the consent form so that Dr. Chung has time to go over the AD guides. So this project could last up to 24 months. You might see me in the clinic, or I'll be doing the practice facilitation over Zoom. What would be asked to do in the study? You and your practice will enter into a training and practice transformation process that will build capacity for practice measurements. You may choose not to participate in the study, and there's an option on the consent form where you can click yes or no. The practice does get reimbursed for $150 and then additional towards the end of the study at the end. You can withdraw at any time, but if you do, reach out to me or your office manager. And then so that way we can review and see if it's a good time to continue on or go ahead and withdraw from the study. There's no risk to participating in the study. Please note that you may release names that are part of the practice, but no individual level data will be released. And I know I'm going over pretty quick, but there's also, you'll get the form and you'll also receive a copy in your email. And then, like I mentioned earlier, taking part in the study is voluntary. And then it's on the top, it talks about Dr. Stephen Crawford is the main primary investigator. And then it talks about the Joel Nicaldi and Lee Jennings. And at the bottom, it asks to type in your name and sign, and you'll do that electronically. So once you go to the bottom of the form, you'll enter your first name, your last name, and then you'll click on yes or no if you're authorized to make decisions for the practice. And then if you click yes or no, you agree to participate in the study. And then for signature part, you'll take your mouse and you'll add signature. And once you click on that, a box pops up. You'll sign with your mouse or your finger, depending if you're using a tablet, and you'll click on today's date. And then you'll go to the next page. And then you go to the next page, you'll see this green box, and then you'll click on it to make sure everything's correct. Once everything's correct, you'll click on the submit button. And once you submit your consent form, I'll receive notification that it's ready. And then you'll also receive another email in your inbox to do a practice member survey. The survey could take about 5 or 10 minutes or less. And after you submit your consent form, you will receive an email from me to request a PMP data report. You don't have to worry about filtering it or sharing or uploading to the shared drive. I will do that for you. That way, when we get all the lists from the providers, we're able to randomize it. And then that's when we start our patient recruitment. Anyone have any questions on the consent form?
No.
Okay. Thank you. So right now I'm going to stop my share, and then I'm going to upload the academic detail guide.
Y'all ready for me?
Yep.
Okay. So thank you for allowing me to be here with you this morning. I'm feeling like I'm preaching to the choir. Seems like we all do this very well, but it's a good project, worthwhile project anyway. And the slides are very short. They're only 22 slides, and most of which we all quite aware of the content already. But I'll go through it very quickly so that you can get on with your business. So the project is Arise OK, standing for the Reducing Inappropriate Opioid Use in Seniors in Oklahoma. Obviously, opioid use is a problem for Oklahoma. Certainly, we see that there's a large number of Oklahomans who have been and are being prescribed opiates. And I think that for many years, I certainly have been guilty of that we feel like, the person gets older, it's a lot safer to give them opioids and so on. Yet, as time have gone by, we recognize that there is a significant problem there, especially with combination of medications that the elderly patients are typically on. Next slide, please. And that's just housekeeping. Next slide, please. All right. So what we see is that 30%, at least 30% of older adults in the U.S. report having some chronic pain. And out of those folks, 2/3 of them will have chronic pain that are bad enough that are interfering with their activities that they enjoy. And in our clinic, we certainly see the same. We have had a program for pain management that we administer ourselves for our own patients, and those numbers really do translate into what we see. And as you can imagine, older patients who are on opioids do have a lot more complications. Consequences include increased falls and increased depression and anxiety, sleep impairment, which is already a significant problem. Social isolation gets worse. There's a potential for misuse of the opioids. And I would say at least once a month, we run on our inpatient service, we see folks who are come in who have mental status change that eventually we work that up and we recognize that that's just an opioid overdose, whether it's intentional or as an interaction from with other drugs. Next slide, please. So what we recommend then is we limit opioid prescribing only for acute pain. And again, I'll go through this very, very quickly. We all know this. If there are things that we can do that are short of opiates, and we should be doing it. But if opiates are required, then we do it. And we do it for a very short period of time. I think that for this group, I think we all know this. Next slide, please. All right. So if we are prescribing opioid for an acute pain, new prescription for acute pain, again. Short course, a few days, 3 days or so, or fewer, and continue on the non-opioid treatment that we already started, and be aware of co-prescribing. We've had, many people have not enjoyed using the PMP, but I've certainly found it to be extremely, extremely useful because now we know what the medications the patients are on. Whereas in the before that got started, you never knew who else has been prescribed to the patient. So certainly checking PMP has been wonderful on my end as also as a faculty, because frequently I have to authorize medications that the residents want to prescribe. So if we take that another step and we're prescribing opiates for acute pain on a patient who has already been on long-term opioids, and again, at least once every couple of weeks, we have to deal with this, and that, patients have a surgery, a dental procedure of some sort, and they've been on long-term opiates, and now that we have to escalate for a short period of time. Again, I think that frequently we just kind of automatically say, okay, you've been taking 90 hydrocodone tablets a month. Now we're going to give you an extra, 5 days or 4 days or 3 days at a higher dose. But I think frequently we stop short of thinking about the non-opioid medications that could also be used for whatever treatment that is. Somebody has an ankle injury or something, certainly treating them for that injury is appropriate. Next slide, please. All right, so for chronic pain management, though, what we've learned from our practice in particular is that, to refocus that encounter rather than how bad your pain is and everything about pain. We refocus that encounter to functional status. What's your day like? What things that you like to do that you haven't been able to do? What else had you been doing? So more of a focus not on what am I going to do to make this pain go away, rather than refocusing on more of what we're going to do to help you gain back the function, the enjoyment of life that you had prior to this event. Next slide, please. And certainly an assessment, as you all know, we screen for depression, screen for anxiety. We evaluate the whole person, everything about that person, from a social to psychological factors and spiritual factors, as well as the physical. And what I found in our practice in particular that's very interesting is there's a significant under diagnosis of depression and anxiety. And the anxiety component in chronic pain cannot be understated, as I think that many folks have this fear also, rather, other than just their anxiety, but have this fear also of what's going to come next when they have the pain. Next slide, please. I think this slide is a little bit busy, but I think that frequently we don't do a good job of being a little bit more precise in what we're treating in terms of chronic pain, whether it's a neuropathic pain versus nociceptive pain, or a combination of both, because the treatment, as you can see here, is different. If you have neuropathic pain, anticonvulsants do help, whereas nociceptive pain, it's probably not going to be very helpful. And on the right side slide here, you see that a lot of things in neuropathic pain, acupuncture probably is not all that great for it. I think that we just have to do a bit better job of deciding what it is, rather than just calling pain as a pain and just prescribe an opiates. All right, next slide, please. All right, so what do we do? What do we recommend? We say do no harm. The do, as you can see there, to assess the pain, what type of pain it is. And frequently, it's real easy to inherit a patient who's been on pain medications for a long time and say, okay, this person has chronic pain, and we're going to continue with the treatment or not, rather than just assess the pain anew. And then create a pain management plan, and then set the goals with the patient, along with the patient, for his or her improved function. And don't forget to prescribe naloxone for these patients as well. We don't just give refills for no reason. In our practice, for example, we don't do refills over the phone. Every prescription will be with an encounter. And we require all of our folks to look at medication list and have an updated medication list to review before we authorize a refill. And harm reduction is important. Just as we don't continue to give people antihypertensives that don't work, if an opiate doesn't work, why are we continuing to do that, right? If the patient exhibits significant side effects, we need to remove the patient or remove that prescription. Patients who have opioid use disorders or patient have behavioral health problems, we need to investigate that a little further. We have an agreement in writing. I think that, in the state of Oklahoma, everybody has that now. But in our practice, we certainly have that as well, and an agreement that gets renewed and reviewed and renewed. And we insist on one prescriber and one pharmacy. Now, granted, in a residency practice, that could be difficult because you have a lot of residents and so on. But still, we try to get those patients back to that resident provider, that resident physician, as best as we can for the refills. And then PMP recheck. And then prescription, the R stands for prescription for opioids using the lowest effective dose. We used immediate release formulation and 3 to 7 days only for acute pain. And we limit the MME to 50 or less per day. All right, and then we monitor, M for monitor for progress toward functional goal, for any evidence of misuse, and for side effects. Okay, next slide, please. All right, for the patients who are already receiving long-term opioids, what do? Well, we screen people and we look for substance abuse disorder or mental health problems that we can address. And we check the PMP every time. And frequently in our practice, our patients are now, they know that when they come in for these visits, they're going to bring their pill bottles in. We do a pill count and so on. But basically, we don't just say, okay, well, you've been on 90 pills a month. We're going to continue with 90 pills, but it's an actual active program of reducing the use. Now, granted, there are many people that they're going to be reduced to the lowest number that they're already going to be on. So whether that's 60 a month or 50 a month or 80 a month or whatever it is, but we don't just stay there all the time. Periodically, we have review of that and along working with the patient in trying to reduce the maximum amount of pills that they take in a monthly period. Okay, and if we suspect that or we detect any evidence of mental health, we certainly are very aggressive in getting folks to the help, getting the help that they need. Now, granted, that's sometimes very hard for physicians out in the community. All right, next slide, please. So how do you taper opioid doses? We, for every encounter, looking at the PEG score is important. That's the pain, enjoyment of life, and general activity. And again, I'm sure all of you are very familiar with that, so we'll go through that very quickly. But we are, every visit that we have with our patients, we certainly do that. Patients already know by the time they get to our practice what their numbers were the previous month and what this month their numbers are. And we listen to the patient, talk to the patient about what's better, what's worse, what is what has happened this month, and frequently what we see is it's more psychosocial rather than physical. Very occasionally you see the more physical things, but frequently it's stress of life, make their situations worse, and so on. And we try to reduce and taper the dosage as best as we can. Now, frequently, again, that's not successful, but we review that and we offer additional therapy and so on. Now, the taper regimen itself is going to really depend on what the patients are willing to do. You have to have buy-in for the patient, and certainly, I've been very successful at that, and our residents have been successful at that. But life happens, and if let's say you agree on a 5% reduction every month, and then wintertime comes and folks hurt more, and they're not going to be willing to continue to reduce at the same level. So sometimes we give them a break from that taper regimen, and then we continue on at a time. But all of these things are done with the patient, with the patient's buy-in ahead of time. Next slide, please. All right. So here it is. You have to balance what the patient's concern is with the benefit of tapering. And I think that at the beginning of these encounters, and setting the right tone and motivational interviewing techniques and so on is very helpful. I think that the thing that really throws a problem into our process is medical marijuana. And I don't know what your practice is like, but our practice, gosh, just about everybody I know has a medical marijuana card. And I haven't seen one yet who has been successful in reducing their opiate use once they got on the marijuana. Now, one could argue that, maybe we've been undertreating their pain. That's why they're using medical marijuana in addition to the opiates. Every practice is going to be different. You have to decide what's appropriate for you. But we certainly see this, and we try to reduce the medication again to the lowest effective dose and the lowest amount that the patient the patient needs. Right. Next slide, please. All right. So substance use disorder certainly is very prevalent in our population of patients who are on chronic opiates. That's a selection bias, I'm sure. But we screen for this, and we continue with screening periodically. And the patients who meet the substance use disorder diagnosis, we don't just discontinue them from our program. We actually try to get them help. Again, there are people you try to get them help for this, and they just leave and they go somewhere else. But we certainly try our best to get help for the folks. All right, next slide, please. All right, so here's the identifying. This is SBIRT that we're talking about: the screening, brief intervention, and referral to treatment. Again, I mean, we do all of these things, I think, as a group, all of us, but some patients are willing and some who are not. We have behavioral health in-house, and we have an integrated behavioral health system in our practice. And I would say probably 30 to 40% of our patients take advantage of that. The rest, they say, well, you're not going to prescribe these medications to me. Doesn't matter that you think I'm at higher risk of misuse and so on. I'm just not going to come back. And so unfortunately, that happens. All right. So that is actually the end. And then there's like a tool. Go to the next slide, please. Additional resources, right? OK toolkit that you all have, and things like that. After that, it's just references. And I'll take questions. Anybody have questions? And
Terry, how long do you set aside for these routine, the follow-up visits, not the initial evaluation if it were a new patient?
Right. So our program is called a CPSM, so Chronic Pain Self-Management Program, and it's not open to everybody. It's open only for our patients. So frequently we have patients that come in either as a new patient wanting to get established, or an established patient who is now, for whatever reason, has been on pain medications and now are in a chronic situation. The initial is 45 minutes. We have behavioral health on, but the follow-up visits, we all have to deal with RVUs and we all have to deal with production and so on. And so it's an ongoing debate as to what we should do for these folks. We have to take into account the patient's ability to come in for visits as well. Because what we have found is that if we're not careful, we can never take care of the patient for anything else other than the pain medications. They'll come in and they'll take, our visits are 20 minutes for residents, a 20-minute slot, and it gets dominated. It just gets dominated by all of these things. So what we do then is that for the 20 minutes that we have, sorry, I'm getting a lot of echo feedback here.
It's next week, next Thursday.
Okay, so typically it's 20 minutes and it really 20 minutes is more than plenty of time. Probably most of us can get this done in about, like my own patients, I can get that done in about 5 to 10 minutes, because it's a matter of the PEG score, the discussion with the patient about what has been working, what has not been working, what their lives are like during that period of time, going through the medications and so on. So and refill of medication, checking PMP, refill medications. So it could go very quickly. And so we try to get the patients to come in only for the pain management visit and nothing else. If they have other issues, we make an appointment and another time. So CPSM or pain management visits are monthly visits. And then in between there, if they have medical issues, we ask them to come back in between. I'm sorry, that's a very long answer to your question.
No, thank you. I guess I take some comfort in knowing it's as much a struggle for you as it is for us over here.
Oh gosh, it's always a difficult issue for our patients who rely on Sunaride, for example. Then how do you take care of diabetes and heart disease and depression? Depression is like the worst one. You can't just say, great, you have depression, here's a pill, and then on top of it, pain management.
Dr. Truong, I have a question for you. I'm really impressed with the continuity that you're offering these patients. How do you do the resident and faculty patient panel size management in order to ensure access to a monthly appointment with interim visits for other reasons?
So what has happened is that, again, we've had this for quite a long time, so we've had plenty of time to really mess up and figure out what doesn't work. But the way that we do this is we try not to get the interns to many of these patients, because as you can imagine, interns don't have that much time in the clinic. And then the upper levels, we have a database. We keep track of a list of number of patients. And then when third years are graduating, for example, at this time, we've already had a conference where those patients are presented again in conference, and we reassign those patients to a second year, a few to the first year. For somebody who, let's say, has chronic pain, but rarely needs to come in. There are people who come in once every 3 months because that's all they need. Then for some of those people can go to the first year. Other than that, it's usually second year or another third year. We try as well to do a warm handoff as much as possible too. So the very last visits that the third year would have, they would bring in the second year, say, hey, I want to introduce you to the new doctor. Occasionally we send a patient to a first year. So there's a patient I've known now for 20 years since I've been there. And ever since I've been at this practice, for whatever reason, Medicaid assigned her to me as the doctor who can prescribe her the medication. So I've known her all these years, and so we reassign that lady to our first year resident, and that's all we can do. And we say, ahead of time, you have to figure out if you're going to be on vacation, then maybe you need to get the patient in sooner, and write the prescription and explain to the patient that the 30-day pill count is still the same, even though you might get the prescription earlier. Any other question? Okay, so if you have other questions, certainly you can email me, call me, whatever. I'm, my lines are always open to you. I'll leave then and leave you to your faculty meeting. Thank you for having me this morning.
Thank you.
Thank you. You'll be
Have a good one.
receiving an email from Dr. Stephen Crawford, and then I'm going to send you the recording to this video. Thank you.